Hello, everyone. My name is Noah. I'm the communications coordinator for Voices for Vaccines, and today I'm here with Dr. Paul Offit, who is a respected scientist, pediatrician, and vaccine expert. Today, we're going to be talking about the surge in respiratory viruses that has happened this winter, including flu, RSV, potentially COVID coming back. There's a lot of sickness and people asking a lot of questions about what to do and think about these different diseases. So the first kind of set of questions or topic I want to address is about kids and kind of their relationship with viruses over the past few years has been altered. Kids tend to get sick pretty often. I think it's like 6 colds a year. They get flu, they get RSV, whatever. And to a certain extent, that's said to help make their immune system more robust. At the same time, pneumonia, bronchitis, asthma, these are leading causes of children's hospitalization. By some accounts, they're the major causes of children's hospitalization. How do we square, this idea that they need some exposure to antigens, but these diseases aren't benign?
For diseases where you have a vaccine, you'd prefer to have the vaccine. I mean, the goal of a vaccine is to be able to induce the immunity that is a consequence of natural infection without paying the price of natural infection. I mean, the fact is, RSV, for example, respiratory syncytial virus, is a common respiratory virus. We see it all the time in our hospital. Every October, November is when it starts, and then it sort of peaks around December. We see it every year. But the point is, we see it in the hospital. Now, which is to say that virus can cause not only a cold, but it also can affect the lungs, specifically the small breathing tubes, causing inflammation in those small breathing tubes, so-called bronchiolitis, which causes wheezing and sometimes requires hospitalization or admission to the intensive care unit. It's not a big killer in children, but about 100 to 300 children will die a year, typically less than 2 years of age, of respiratory syncytial virus. We don't have an RSV vaccine, but there will be an RSV vaccine probably within the next 2 years. I really do think an RSV vaccine is right around the corner. People have been working on it since the 1960s, so it's been 60 years, but we're getting there. Influenza, obviously we have an influenza vaccine. This is a bad influenza year, as was predicted, because usually what happens in countries like Australia or South America, whose winters precede ours, will predict what goes on in our country. And so that's what, you're seeing a major increase in flu. The good news is that the flu strains are circulating are well matched by the flu vaccine. So therefore the flu vaccine will be protective against serious illness. But I think there's nothing good about natural infections. I really would like to know who Mother Nature's public relations team is, because she's pretty much been trying to kill us ever since we crawled out of the ocean onto land. Natural infections are something we deal with in our hospital all the time. That's never good. Natural polio was not good, and these natural infections are good. But if you survive them, then you have an immunity that you wouldn't have otherwise. Hopefully we'll make vaccines for these other infections like, RSV, parainfluenza, and all the other sort of respiratory viruses that come into our hospital in the winter.
One of the things people have been asking as well, you don't want to approach hygiene hypothesis level, but there's this idea of immune debt or immunity debt from the past few years. Obviously, because kids have not been, nobody really has been getting a lot of different diseases. And so I guess the question is there kind of an immunity debt? Is that like a real thing? And is that like a consequence we should have foreseen, or maybe are paying for because we avoided COVID?
All right, so there's 2 questions in there. I'll address them separately. The first is the notion of the hygiene hypothesis. I just want to talk about what that is, and then immune debt, which I do think is a real thing, and we'll talk about it. So the hygiene hypothesis is that the more that you are exposed to all the sort of germs that are out there early in life, the less likely you are to develop the kind of allergic responses that you see things like asthma and atopic dermatitis and psoriasis, et cetera, that you see less of that. And that's true. I mean, so for example, in African nations, the incidence of asthma is much less there than it is in the United States, in a Western sort of society. And there was actually an op-ed piece in the New England Journal of Medicine decades ago, which had the title, "Eat Dirt, Please." And that's what it was referring to. The more you're exposed to earlier, the less likely you are to develop these kind of allergic symptoms. That's really irrelevant to vaccines. I mean, vaccines, there's only, 14 different vaccines to prevent 14 different diseases in the first few years of life, 17 by the time you're an adolescent. That's trivial compared to what you are exposed to all the time. So that we vaccinate our population is not why we have higher rates of asthma and other allergic phenomena. So if you look at for example, in African nations, those children are often exposed to a variety of different bacteria, including toxin-producing bacteria of their intestine, parasites in their intestine, which is something we generally don't experience nearly as much here. So the hygiene hypothesis is irrelevant to vaccines. In terms of immune debt, yeah, I think there is such a thing as kind of this kind of immunity gap or population gap when it comes to what's happened recently, because this was a bad RSV year. I mean, I've been practicing infectious diseases in pediatrics for 40 years, and I can tell you I have never seen an RSV hit as big as we've had this year in our hospital. I mean, there were times when we had 140 children in our emergency department who we triaged, but never actually got to bring back to a room and it was all hands on deck. I mean, all the fellows, attendings had to come down to the ED if they had a moment to try and help handle the onslaught of RSV that we saw. And flu is taking off now. I mean, people talk about the tridemic now. I mean, it is December 9th, 2022. People talk about a tridemic. I see this more as a bidemic. I think it's RSV and flu. There'll be, I think, a lot of COVID infections in the winter, but I really don't think we're going to have that concomitant increase in hospitalizations and deaths as we saw last winter or the winter before that, because we have such a high level of population immunity now with COVID. The estimates are at least 95% of people have either been naturally affected or vaccinated or both. But regarding a sort of immunity debt, if you will, we did something in 2020 we've never done before. And the results were remarkable. When SARS-CoV-2 came into the United States in January, February of this year, we didn't have anything. We didn't have vaccines, we didn't have monoclonal antibodies, we didn't have antivirals, and we had a blank slate. No one had seen that virus before. And you knew that it could cause hospitalizations and ICU admissions and deaths. And the only thing we had was to try and keep us from interacting with each other. That's all we had. So we closed businesses, closed schools, restricted travel, masked, social distance, isolated, quarantine, and tested. That's all we could do. And what we did in that year was we eliminated RSV infections in this country. We saw no RSV in our hospital in the winter at the end of sort of 2020, beginning 2021. And influenza, which typically kills between 75 to 150 children every year, killed one child that year, which tells you how much worse I think SARS-CoV-2 would have been had we not done what we did. But what happened is then RSV and flu weren't circulating that year. And so they weren't sort of building up that kind of population immunity. And the same was really true the following year. So although we weren't as restrictive in 2021, and we had antivirals and we had monoclonals and we had vaccines, we still were masking and social distancing and very slow to get back to life as normal. But this year, it's life as normal. And I think people are playing and living and working the way they normally did. And so you're seeing much more interaction. I mean, you go to, a 76ers game, and I don't recommend that actually, but if you go to a 76ers game, you're in a closed space with 20,000 people and no one's wearing a mask and they're screaming their heads off, mostly booing. And you would have to know that to watch the Sixers to understand that. But I think what you're seeing now is that lack of what was the circulating viruses that were able to really create a lot of population immunity and therefore lessen the spread of those viruses.
That makes sense. And the tripledemic term, actually, you're right. I mean, that has caught on. I think a lot of parents are really more aware of these viruses probably than they have ever been. A lot of people are hearing RSV for the first time, even as a term. And there's plenty of people saying, my kid's in the hospital with, whatever. I mean, it's been RSV for the past month. It's, transitioning to flu. Parents are worried about it. It's not necessarily likely to, be super severe for their kid, but they are worried about it. Do we have to just kind of accept that we're going to be more sick this winter, I guess would be the question.
You would be hard pressed to find a 10-year-old in this country, even before the pandemic started, who had not been exposed to RSV. I mean, it is a common infection. So therefore, obviously, most children have been infected by the time they're a few years old and survive because the virus, although the virus kills 100 to 300 children a year, there's 3.5 to 4 million children born every year. What I would say is when parents should worry is when they're having trouble hydrating their child, meaning getting the child the fluids that they need. So there's a decrease in tearing or decrease in urination. And then most importantly, if you think your child is having trouble breathing, then please go see a doctor. But otherwise, it's a matter of sort of fighting through the colds. Even fever wouldn't necessarily necessarily be a marker, because fever occurs as part of our immune response. When we make fever because our immune system works better at a higher temperature, that's why we do that. But if you're worried, obviously bring the child to the doctor. But the two things to focus on are hydration and breathing. And assuming that's still okay, then I think you don't necessarily need to rush to the doctor.
And maybe from the prevention angle as well. So I know a lot of doctors give kind of health advice with, wash your hands and, over COVID, just wear a mask. And would you recommend that families maybe do more? Or is it just, again, like these communities are going to be affected? If you get sick, go to the hospital?
I think we've learned something from 2020, which is if you do what we did in 2020, we eliminated these respiratory viruses like flu and RSV, at least for a year. So therefore, distancing does matter. I think what strikes me is I have some friends who have young children that when their children have a respiratory infection, and they all look alike, whether it's RSV or influenza or SARS-CoV-2 virus, or the 4 strains of human coronavirus or parainfluenza, they all start congestion, cough, sore throat, fever. That's how they all start, and they're all contagious. Actually, you're most contagious a couple days before you develop symptoms. But and so some of my friends, like, they'll test their child, find that they're COVID negative, and go great, and then send them off to school because they figure it's good. They don't have SARS-CoV-2 infection, but all those infections can be dangerous. And so I think probably the smartest thing to do, if you test, great, but if you don't test, just assume that the child has a respiratory infection, which is contagious, and keep them home if you can. And you, frankly, if you have signs and symptoms of those respiratory infections and you can stay home, you should stay home. If you can't stay home, then please mask. And I would argue the same thing for children if they just can't stay home. There used to be an old term, which was absenteeism, meaning how many people, for example, in our hospital, nurses, doctors, weren't able to come to work because they were sick. The new term is presenteeism, meaning people who come to work even when they are sick, and thus put others at risk. So I think we're going to have to fight presenteeism. And maybe what we'll evolve to is that what we've learned here is that for any respiratory infection over the winter, stay home if you can, wear a mask if you go out, which is done in a number of Asian countries. It's not just, it's not a new concept, but I wonder whether it's a concept we'll ultimately adapt. I think some will.
And that's actually something I did want to ask about a little bit later on, but this is a good time to. I mean, do you still think masking then is a tool that should be used? And obviously, I mean, you could go all out all the time in mask or not do it that often, but do you think there should be kind of a shift towards maybe masking more than we did before, doing kind of more of that prevention stuff on an individual and community basis? Like, what maybe is reasonable to keep doing from what we were doing during the pandemic?
Right. So I think what's happened is the vaccines were first available in December of 2020. And throughout that first year then, from December 2020 to December 2021, the variants that circulated in this country were very much susceptible to protection against really all manner of symptomatic illness, mild, moderate, severe illness. The mild illness protection was maybe 6 months or so, but protection against severe illness was certainly at least a year long. Once Omicron came into this country and all the Omicron subvariants like BA2, BA3, BA4, BA5, and then these even newer subvariants, those variants were resistant to protection against mild disease. So even if you were vaccinated or naturally infected or both, even recently, you could still get a mild infection because those strains really avoided recognition by neutralizing antibodies. They still were recognized by another part of your immune system called T cells, and that's why we're all still protected against serious disease if you've gotten vaccinated or naturally infected. So that's the good news. Despite all the variants you've heard about, from the first virus, the ancestral strain, right up to the current variants like XBB and XBB1, you're still protected against severe disease. So that's good news. But I think that in terms of masking, remember that these new variants are not as well protected with the current vaccines, including the bivalent vaccines, as you were in that first year. So you still can get a mild infection, which means you still can be contagious because of these new variants. And I think it is reasonable. You're hearing now Dr. Rochelle Walensky, who's the head of the CDC, is now talking more about let's mask whenever you're indoors in the winter months. And I think that's fair. I mean, I think that's reasonable. I certainly mask whenever I'm on the bus on the way to work in Philadelphia.
And then just to kind of tie one more question related to that, again, people do have fairly good protection against COVID if they've either been infected or vaccinated, most both at this point, which would give you a fairly good amount of immunity. But there are still some risks. There's still ability to transmit to people who might have multiple comorbidities or be much older. And so if somebody is trying to mitigate and reduce risks from COVID going forward, what should they do? What would be your most practical advice for a person like that?
So this virus is going to be with us for years, if not decades, if not longer. I mean, there are 4 strains of human coronaviruses. 2 of them were first identified in the early 1960s. Researchers at Penn and other places have looked at trying to answer the question, when did those viruses first come into the human population, both of which probably originated in bats, as this virus did. And the answer was probably late 1700s in one case and late 1800s in another. Influenza has been with us since the 1300s. Let's assume this virus is going to be with us for a while. So how do we handle this moving forward? I think we have to really pay attention to the most vulnerable groups. Number one, far and away, the elderly, people over 75 years of age. And then people who have multiple comorbidities, meaning health problems that put them at high risk of serious disease should they get even a mild infection. That could land them in the hospital because they're somewhat frail because of all those health problems. And then people who are immune compromised. And some of those people don't make a very good immune response. So you can keep vaccinating them, but they're still not making a good immune response. So those groups, especially the elderly, need to take Paxlovid in that first few days that they're ill to save their life. So I think that gets underemphasized because we keep thinking that vaccines do everything you need to do, and that's not always true. So I do think moving forward, 5 years from now, 10 years from now, 20 years from now, you need to protect the people who are most likely to die from this. And this virus, even more so than flu, really does kill the elderly. So for example, when the virus first rolled into this country, it was nursing homes that really were hammered. And flu will kill, has maybe 40% of the deaths are in nursing homes. It was much higher here. I mean, I think really more than 90% of the deaths now are in people who are older because vaccines only work so well, and I think we underutilize Paxlovid. So I think that's who you need to focus on moving forward. Protect those groups.
For sure. And I guess a question that might tie into that as well, just to extend a little bit more, there's a certain cost of normal in terms of these diseases that go around. I think that we not necessarily accept, but people realize that okay, if we go about life as we do, flu is going to kill 10 to 60,000 people every year, and it did. Can we live a normal life and really take those numbers down? Because if we don't right now, then we're going to have the COVID burden still be, a 5-digit number for the rest of forever. Can we actually mitigate it while still maintaining a quote unquote normal life?
Well, I think this virus will sort of enter the pantheon of winter respiratory viruses and will, like influenza, probably moving forward cause at least tens of thousands of hospitalizations every year and at least thousands of deaths every year. I would imagine that would be true. And I think we will probably handle this virus the same way we handle flu, which we will grandfather in a certain amount of disease and a certain amount of death and live with that, which is what we're doing. I think at this point, and President Biden said it, and I agree, he said, I think we're past the pandemic, but the virus will still be with us. And I think that's true. I think people misinterpreted that to mean that, that nobody's going to suffer or die from this virus anymore. I think he was just saying, he was defining pandemic as something that changes the way you live, work, and play, which it really isn't true anymore. People are, for the most part, back to life as normal. And so we are going to be living with this virus, and we've chosen to live with this virus and die with this virus at a certain level as we did with flu. I mean, but 2 years before SARS-CoV-2 entered the United States, there were 800,000 hospitalizations from flu and 60,000 deaths. We could mitigate that if we wanted to by masking and trying to social distance in the winter months. We don't do that. I suspect that's what will happen here as well. I mean, what you hope doesn't happen, and it might, is that flu mutates to the point that even natural infection or immunization doesn't protect you against severe disease. If that's true, then we're starting all over again with a vaccine. Hopefully that won't happen. It hasn't happened yet.
And that, I guess, goes to the booster question, the one booster question I want to ask and try to not ask anymore. But I think, like you said, there's not really much the public is doing in terms of mitigations at this point. I think most people seem to agree that's the case. There are individuals who are masking. There are some communities that are masking, doing other things. For the most part, the team effort behind COVID is kind of gone. And so I think that the argument people make for the boosters, or for what's happening with using boosters, I guess, however many times, is that we're not doing anything else, right? So my question to you then would be, away from the FDA stuff, because again, I can't argue the science, but away from that, is boosting people, is using vaccination as kind of our last tool for the public, preferable to the alternative of doing nothing?
Yeah, no, I think if you looked at the first year, there was a study done by Mark Tedford and coworkers that was published in Clinical Infectious Diseases that looked at how well we did in the first year, meaning vaccine comes out in December 2020. How were we doing in December 2021 when we'd suffered mostly the Alpha and Delta variants? Was 2 doses of vaccine working to protect against severe disease, which is the only reasonable goal for this vaccine, protect against severe disease. And what they found was that it was for all age group, it was for all comorbidities, it was for both vaccines. That was working as a 2-dose vaccine. Then Omicron hit and the Omicron subvariants. And the CDC did studies trying to answer the question, do you benefit from a 3rd dose? And the answer was yes, you definitely did. You lowered the rate of hospitalization with that 3rd dose. And then later they showed that to somewhat of a lesser extent, but still you lowered the rate of hospitalization with the 4th dose. But the question is who was benefiting? Because it wasn't everybody. The groups that benefited again were the elderly, the immune compromised, and people who had multiple comorbidities. So focus on them. I think we need to focus not just our vaccine efforts on them, but our antiviral efforts on them if we're going to try and impact people moving forward, because those are the ones who are at greatest risk. And I do think that we dilute the message somewhat when we say, or when the CDC says, let's vaccinate everybody over 12 and then everybody over 5. And now I think as of a couple of days ago, even everybody less than 5 up to, and over 6 months of age. I just think if we're going to have the biggest impact, we really should, the public health message should be on to focusing on those who are at greatest risk.
For sure. And maybe a question I would pose to you then. So if you think that maybe the booster message is untargeted, if you were trying to convince somebody who you think would need a booster or a vaccine, could you try and reach them specifically with, they might be concerned with the politics or it's unnecessary or whatever? I mean, what would be your pitch for a booster right now for somebody who needs it?
Well, so the data support the notion of boosting those who are in those highest risk groups. And so if you're in that high risk group, so my mother, for example, who is in her early 90s, should she get a vaccine? Absolutely. She needs to protect herself by boosting antibodies to the degree that she can over those first few months of the winter. And should she get ill, then I would obviously very much encourage her to get Paxlovid. So she does listen to me, so that's good. My children don't listen to me, but my mother still listens to me, so that's good. So
the people you would recommend then would be people who are, again, like over the age of 65, maybe have different health conditions and whatnot. Okay, gotcha. Actually, do want to move on to the RSV vaccine quickly, and again, don't have too much time, but just wanted to ask, is that coming soon? What are your thoughts on that?
I think there will be I think there'll be maybe 3 RSV vaccines. I think one will be for pregnant women, in much the same way that we have a whooping cough vaccine for pregnant women and an influenza vaccine for pregnant women, because that vaccine then will both protect the mother, but more importantly, will protect her unborn child, because a lot of the flu deaths occur really in the first 6 months of life, and it's hard to get young babies to have a great immune response. So by immunizing the mother, you protect the child in those first 6 months of life. Then I think there would be a vaccine for young children as well that would be given sort of in the first and second year of life. And then most importantly, arguably, are again the elderly. If you look at who really dies from RSV every year, there's 6,000 to 10,000 deaths every year in people over 65. So I think there also would be that group as a target. But we've had a lot of trouble making the RSV vaccine. There was an RSV vaccine that was made by researchers at the National Institutes of Health in the early 1960s. And what they did was they took RSV, grew it up in cell culture, purified it, and then inactivated it with a chemical. It was a whole killed viral vaccine, much as the way the hepatitis A vaccine is made or the inactivated polio vaccine is made. And it didn't work. To say it didn't work is an understatement. You were worse off getting that vaccine than not. It never became a commercial product. But in the trials that they did, they found that people who got the vaccine, children, and then were naturally or exposed to the natural virus, were more likely to be hospitalized than those who never got the vaccine. And the reason is the nature of the surface protein of the virus. The surface protein that the virus, respiratory syncytial virus, fuses to cells and then enters it in much the same way that SARS-CoV-2 does or measles does. And so the fusion protein was altered in a way that didn't benefit people who got this vaccine. And we had to figure out how to basically lock this fusion protein into its pre-fusion state, which is just what we did with SARS-CoV-2. So I think both those things happened at the same time. Now we can have a purified protein approach where we lock this fusion protein in its pre-fusion state. It makes it much more immunogenic and much more likely to protect. So I think an RSV vaccine will be right around the corner. I think it'll be widely used because people just saw what we went through this year with RSV.
Excellent. And with the, I know the safety concerns, so the trials seemed to make the virus, this was again 1960, so a long time ago, made the virus worse for those who got infected. How can we, seems like you described how we can kind of be sure that won't happen again, but would that, I mean, make certain that this is a safe vaccine if somebody were concerned about what had happened then and what had, this long time process to actually get somewhere where we have one?
The good news is, the sad truth is medical innovations are invariably associated with human costs. That's true with every medical innovation ever. And it was true certainly with the RSV vaccine then, but you found it out quickly. The same thing was true with measles, actually. There was a measles vaccine that was used in the early 1960s, which was again, grown up, purified, and then killed with a chemical. So it was a whole killed viral vaccine. But measles also had a fusion protein. So that also caused people who then were exposed to the natural virus to develop something called atypical measles, where you were actually more likely to get a measles pneumonia. So that was on and off the market very quickly, but you found out quickly. I mean, as you would find out quickly here. So I do think, though, I think we figured out what the problem was, and now that problem has been solved. But the good news is there's systems in place. The minute vaccines roll out to see if there's a problem, and if there's a big problem, it comes off the market. That's what happened with the rotavirus vaccine in the late 1990s, when within the first 10 months of it being on the market, it was found to cause this intestinal blockage called intussusception. It was off the market. But it's a very, very rare event, but it can happen.
And then the last question I have, submitted by somebody, apparently they wanted me to ask, has Dr. Offit ever met Dr. Onit, and would they cancel each other out?
I haven't, but yes, we absolutely would cancel each other out. It's true. It's a really good point.